So here we go. Here is the presentation. So let's wait for a couple more students, and then we will be ready to start. I see only 5 attending, and I'm waiting for a couple more. So at the moment, do you have any questions accumulated related to previous topics? Actually, I'm going to post an online quiz at the educational portal. This is what we are supposed to have. And it will be at the end of the course. I will open it and I will leave it open for over the weekend. You will have 2 attempts, and I believe this is pretty generous offer. Majority of students pass it without any problem. Also, I have tried to extend the current presentation on cranial nerves, because once you are going to be a stomatologist or dentist, you will have to deal with cranial nerves in many cases, and even I frequently see patients with various types of stomatologic dental problems having secondary lesions of cranial nerves. Most frequently, of course, this is trigeminal nerve and trigeminal neuralgia, which is very hard to treat with regular types of analgesics. So this is an interesting thing. And facial nerve lesions. Actually, even without being a dentist, you see these types of problems very frequently. So I see there are plenty of us already here. And I think that at this moment we are ready to begin. First of all, before we start going through every single cranial nerve, I should tell you that we need a proper basement, proper classification, because cranial nerves serve various functions. This may be sensation, motor, autonomic provision, and what is especially interesting, special types of sensations provided by special types of receptors. And these are those classical 5 senses that you remember: vision, olfactory, auditory, gustatory. And actually, classification of cranial nerves, which is accepted for today, is the following. First of all, general versus general afferent versus general afferent is typical only for spinal nerve, because they serve just 2 functions, motor and sensory. And in cranial nerves, there is a much bigger choice of options, and we have 3 types of classification, 3 axes of classification. The first is based on the receptor type, and general means just like spinal nerves, and this is superficial, pain and temperature, and even proprioceptive sensation, while the other use special receptors. And concerning signal type, everything looks similar. Afferent is sensory, afferent is motoric. Voluntary versus reflexes. And here we should remember a thing which is not frequently noticed in segmental part of PNS: somatic and visceral, autonomic and voluntary control. Somatic group of nerves innervate somatic skeletal muscles, and this is voluntary muscle. But if we speak about tiny muscles innervating pupil constriction, or if we speak about smooth muscles serving the esophagus function, contraction, then this is a subject not within voluntary control. This is the list which you definitely remember, and when you are on anatomy course, teachers usually tell that I should be able to wake you up at night and tell you, for example, 6, and you'll respond that this is abducens. But here I would like to offer you an easy mnemonic, a thing that medical students frequently used. This is a rather funny one. You say it, and you use first letters O, 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 T, T, A, F, and this matter. In this way, you remember the number of every cranial nerves. And I will not speak even about the list. This is, by the way, is more correct. I will not even speak about the list because you definitely remember all 12. This is something that I don't doubt. But what is frequently forgotten is location of cranial nerve nuclei. And this is pretty important in neurology because there are multiple nuclei, and nuclear lesions demonstrate involvement of brainstem, which is always a red flag pointing to possible brainstem involvement, and this is a life-threatening condition. 3 nuclei are located in the midbrain, 6 in the pons, and all 9 in the medulla. And I think that you should revive this anatomy, for example. And as far as cranial nerve nuclei exists, when we speak about, for example, descending pathways, we have a very similar classification of upper and lower motor neuronal lesion. And just like in the spinal segment, just like in the pyramidal pathway, sometimes we have to differentiate upper versus lower motor neuronal lesion. Brightest example is Bell's palsy, paralysis of facial nerve. And in this case, we may see patients with absent facial reflexes, flaccid muscle tone, and ptosis, while upper motor neuronal lesion, which usually means stroke, doesn't demonstrate that. Ocular motion is preserved. And sensory pathways also are built up of 3 orders of neurons, with first order outside brainstem, second order cell bodies in gray matter of white stem, and finally cell bodies in ventral posterior medial nucleus of thalamus. Looks pretty similar to sensory pathways in the spinal nerve, but here, of course, we don't involve the vertebral portion, and brainstem serves as a placeholder for location of these nuclei. And what is interesting, there are several exceptions. For example, 3 sensations, smell, hearing, and vision, are rooted in a different manner. For example, olfactory sensation is not even going through the thalamus. This is the only type of sensory input which doesn't go through the thalamus. And for optic nerve, we will see an optic chiasm and other types of delivery. So let's begin with number 1. And let's remember our classification. Olfactory nerve is a spatial type of sensation. And this is a visceral fiber, and this is, of course, a sensory ascending fibers. And there are 3 parts with olfactory bulb, and it is located behind the cribriform plate. The initial fibers beginning in tunica mucosa of nasal cavity penetrate this cribriform plate, and once they are entered to the skull, the olfactory bulb, the fibers go through the uncus and are delivered to temporal cortex. This is a very sensitive cranial nerve, and of course, the first example, which is tempting to remember, is viral infection. And modern SARS coronavirus has this method of delivery to the brain also. It is just like herpes virus, it's also neurotrophic. But there are multiple other examples. For example, automotive trauma, when a subject is being hit against the steering wheel, and then there is a ricochet movement of the head, and here in the cribriform plate, the olfactory fibers are being torn in parts, and it takes pretty long time to recover. As far as olfactory nerve has a very special way to get to the temporal cortex, not involving the thalamus. It is going through the uncus, and as a result, it has a very high level of association with the limbic system, and possibly we all have experience, and we all know that olfactory sensation is very interacting, is very strongly, has a very strong interaction with emotional sphere. So all the route once again, from fibers going through the cribriform plate, then to olfactory bulb, and then the route of uncus, and finally para-hypocampal gyrus. Also, just physiologically, olfactory ability decreases with age, and this is normal. And there are multiple conditions when it is functionally affected, for example, cold environment or sore throat. And today we are going to have a look at educational video about examination of cranial nerves, and methods of examinations will be discussed very thoroughly. However, testing olfactory sensation is not as simple as it looks. We cannot use very strong substances. For example, alcohol irritates trigeminal nerve already. And there are several types of olfactory stimuli which are being standardized. Nowadays, many patients report that they have impaired olfactory ability, and there are even over-the-counter sets for olfactory training being offered, and this is pretty surprising. I don't have any data on efficacy and safety of this, but once it is being sold, I think it is at least safe. So if someone complains that I have decreased olfactory ability, possibly after viral infection, you can suggest that there are olfactory gymnastics or olfactory training sets. I'll have a look. Possibly there is some link which demonstrates this type of olfactory kits. Oh yes, I have a evidence-based data, so I'll have a look at the chat room, and you may see this is some contemporary things. So this is not a static topic, it develops every day. So next, I think, will be optic nerve. And if we use our classification, this is a special type of sensation, not regular. There are specific receptors, you definitely remember, and three color types, and also black and white receptors located on the retina. And in fact, not all the retina, there is a blind spot in the center, and actually we are trained by our lifetime experience to ignore this blind spot right in the center of our vision field, but there are special tests which you will see today, which can find this blind spot. And why it's important? Because sometimes this place where the optic nerve is attached to the retina increases. There is a swelling of the optic nerve, and optic neuritis is a frequent finding for multiple sclerosis or demyelinating lesions. So, as far as we remember, optic nerve forms a structure called optic chiasm. Actually, every portion of the retina has about half of the fibers decussating and half of the fibers staying on the same side. If you look at the graphic, you will see here that actually every eye delivers visual stimuli to both visual cortices, both left and right. And as a result, There are multiple types of vision deficits, and if we pay attention to characteristics of visual field loss, we are able to localize the exact type of location, the exact location of interruption of fibers. The brightest example is number 1. It is the most logical, and this is called prechiasmatic lesion. Or it produces type of deficit called monocular blindness or amaurosis. And everything doesn't even need explanation. One eye is able to see, the other is not. It gets trickier when it comes to optic chiasm. It looks like a tiny place, but in fact this is sella turcica, and pituitary tumors frequently compress this space, and a type of deficit arises which is called chiasmatic lesion. Right in the middle of the crossing there is a compression site, and as a result there is a vision deficit with the peripheral portion of the vision being affected, and this is called tunnel vision because patients only have so the center of the vision fields preserved. The next type is called prechiasmatic lesion, and it includes several subtypes, and in this case the lesion is behind the chiasm. This means practically that since this point both eyeballs, both eyes, make the sensory input to the pathway. Here we see fibers both from the unilateral eye and from the contralateral eye. And if there is an interruption, usually these are already CNS interruptions. This is already interruption on the level of the central nervous system of its processing. The deficit is called homonymous hemianopsia, which means loss of 2/2 of vision fields. Patients hardly differentiate. For patients, this may be patients may tell you that one of their eyes is not seeing, and they have this impression because they have left visual fields, for example, for both eyes affected. But in fact, the eyes are normal, and only the fibers from 2/2 of retinas are not being delivered to the brain. And once the optical radiations extend and are becoming broader and broader, there are even smaller portions, there are even smaller localizations in the cortex which may produce these deficits. But honestly speaking, it's rather hard to localize it during bedside tests, and we use optically calibrated devices which are called a perimeter. This is are two metallic curves with a graduation on them, and a tiny spot is being moved around this perimeter with patients tracking it, and at some point of time it goes. The next cranial nerve is oculomotor. It's a somatic nerve, and at the same time it's a visceral nerve. It has two portions. One is voluntary controlled and the other is not. And the somatic motor portion is responsible for several oculomotor muscles, for several muscles of the oculomotor complex. And as far as we know, there are two more cranial nerves participating in ocular motion. These are the 6th and the 4th pair of cranial nerves, and all three they form this oculomotor complex. And the visceral, not voluntary controlled, is called is serving the muscle called sphincter pupilla. And if there is a lesion, patients demonstrate first of all pupil asymmetry or loss of response to visual stimulation, of light stimulation. And somatic motor involvement will demonstrate difficulty with eye movements, and depending on this type of deficit, where exactly it's hard to move, we are able to localize the lesion. So here we see that parallel to the optic chiasm, there is a visceral pathway, and it is being served by Edinger-Westphal nucleus. Clinical manifestation of ocular nerve lesion looks like this. So what's actually happening is deviation of the eyeball to the lateral part. And the reason is that the muscles located laterally, like lateral rectus muscle, are served by different pair of cranial nerves, and if it is preserved, it tries to compensate, and it pushes the eyeball towards the peripheral portion. The eyeball is deviated by the result of compensatory activity. Clinically, patient will complain for this. This is called diplopia, or, in speaking in simple words, double vision. This double vision has an interesting additional effect. If the patient synchronizes the eyeball position, if the patient moves, for example, all eyeballs to the lateral, to the same side, then they will be synchronized and diplopia will disappear. This is a very specific and very sensitive test for cranial nerve lesion for diplopia not being produced by central type of deficits, because diplopia is also possible in central deficit like cerebellum lesion. Trochlear nerve is a nerve of peculiarities. It's the only nerve to exit brainstem dorsally and contralaterally, and moreover the muscle goes through a bony block. So as a result, in spite of contralateral exit, clinical effect is similar with other cranial nerves, because this muscle bony block compensates. Clinically, patients have difficulties looking downward when trochlear is injured, so similar to oculomotor nerve, but what you see here, the eyeball is deviated medially. And this is the bony block. Possibly you remember that since anatomy course. That superior oblique muscle is pushing the eyeball to not to the logical direction, but to the contralateral side. Now a nerve of which is important to us, very important. They all are important, but this is twice important. Trigeminal. This is a principal sensory nerve for head, face, orbit, and oral cavity. Moreover, it delivers both general and specific sensation, and it also has motor parts. First of all, it has three sensory branches, which are ophthalmic, maxillary, and mandibular. And you see the distribution of sensory function among these branches of the cranial nerve. And in fact, even anatomically, this is a pretty huge, and before it is being split into three portions, it is almost a finger thickness. And I would say that lesions of trigeminal nerve of these three positions don't start with loss of sensation. They usually start with pain, and by the way, this pain is one of the strongest possible. Usually patients grade it up to 10 points in the visual analog scale. This means very strong. And the second thing is that it is not curable by non-steroid analgesic, not even by narcotic analgesics, because of absolutely different mechanism of pain. And when the pain is produced by irritation of a cranial nerve, we usually call this neurologic pain or neuralgia. And regular somatic pain is a result of delivery of pain mediators to free nerve endings. For example, prostaglandins, substance P, histamine, whatever a damaged tissue releases. But here we have a direct irritation of pain transmitter, and as a result, even if we suppress this pain mediators, cyclooxygenase, by non-steroid analgesics, we get virtually no result, because it is produced in regular amounts in this case, and there is a direct irritation of a nerve. Nothing will help out. It will not help, it will not work if we simply suppress pain mediators. We need to reduce transmission of pain sensation within the nerve. So we need to suppress the ionic channel on the membrane. And what works here very well is a group of drugs used, off-label group of anti-epileptic drugs. And these anti-epileptic drugs were used for partial seizures like carbamazepine or like gabapentin or like pregabalin. These are anti-epileptic drugs which are suitable for peripheral, not generalized seizures. And at the same site, they have a very good effect in blocking of ionic transmission within cranial nerve, and even in spite of several side effects like drowsiness, it is worth doing because patients suffer very strongly from these irritations. What are possible reasons for irritation of trigeminal nerve? Of course, any sort of mechanical interaction. And this is not just stomatologic dental issues. This may be post-infectious neuralgia because of a very high probability of compression of this huge nerve by any type of swelling. Any type of swelling of swollen tissue produces mechanical compression, and the pain starts. So, other portions of trigeminal nerve are spatial visceral afferent portion, and this is a motor nerve for mastication muscles, for chewing and speaking. And you see how many motor muscles are being served by trigeminal nerve. And these are, of course, external and internal pterygoid muscles, musculus temporalis, masseter muscle, and you know the importance of this muscle, mylohyoid muscle, anterior belly of the gastric, and tympanic and palatina muscles, which are principal for not just for mastication but for swallowing act. So these are three branches, but again they are here in this case they are projected on the skin. And this is a motor branch of trigeminal nerve which has a different distribution. You see that there is a big portion of facial muscles being innervated by it. The testing of trigeminal nerve is performed by for superficial sensation. It is done by discriminating touch in facial zones. So we just take this projection and compare the toothpick sensation, and for example, if the patient reports dull touch in the mandibular area but sharp touch in maxillary, then we possibly may suggest mandibular branch involvement. Frequently patients should report not deficit but pain, and in this case pain will also be distributed in accordance with these branches, and your stimuli with a toothpick will produce paresthesias or hyperesthesias. Patients may have even trigger points which they avoid to touch, and they know, for example, if they touch near the ear, then they will suddenly have a very strong pain attack, and they have release points which they touch as a trigger for pain relief. Another option is to check for sneezing corneal reflexes. And the motor portion is compilation of tests for paralysis or paresis of ipsilateral muscles of mastication, which is not very specific because they mainly have bilateral innervation from both sides. However, you should have a look at the deviation of jaw towards side of injury. Unilateral lesion has mild effect on bite strength because of this bilateral innervation, so only bilateral loss gives clinically significant effect. And also we will speak a bit about abducens. and when the class will be terminated, we just rejoin the conference because I have got a warning on few minutes remaining. So abducens innervates only a single muscle, lateral rectus, which moves eye laterally. And when injured, medial rectus muscle is not opposed and either the muscle shifts laterally, you get a familiar deficit which will be demonstrating diplopia again, and again it will be gone only if patient synchronizes his or her eyeballs. By the way, abducens is very susceptible to disruption because it goes nearly behind under the skin in the temporal area, and any trauma of temporal area has a potential for lesion of abducens. So here we go. And once again, this is abducens nerve going, as you possibly may think, very close to temporal area right under the skin. So now I will turn off the conference, and when I'm done, please rejoin because we also have some videos left for today. So what I also want to show you for today is a set of educational videos from Queen's Square University, and I have chosen them, to be honest, for good English and very high attention to even minor detail. And I see only 5 participants are online. However, this will give me a couple of minutes to make the video work right. If you have any issue with sound, please let me know.
The first one is the olfactory nerve, which assesses sense of smell. In order to do this, you need stimuli that are not visible to the patient and should not be noxious or irritating, as that would actually stimulate the trigeminal nerve. The patient is asked to close their eyes and occlude one nostril. I've put a scent under your nose here. Sniff it. And what did you smell?
Cinnamon.
That's correct. Okay. Close your eyes again. Occlude the opposite nostril and take a sniff. Do you recognize that?
Kitchen spices.
A kitchen spice.
Yes.
That's right. And in fact, it's cloves. But many people, just like Andrika, who clearly doesn't spend enough time in the kitchen, couldn't identify that as cloves. So as long as they can perceive the odor and give you an appropriate answer that's sufficient. For the assessment of visual acuity, you can either use a distance or Snellen chart, which is used at either 10 or 20 feet, or a near card. This is the near card, and it is used at 14 inches. The patient is asked to occlude one eye. Cover your left eye, please, Andrika. Okay. And she could either do this with a rod, such as she is using here, or she could use her hand. When the patient uses their hand, instruct them not to apply pressure against the eyeball. Can you read the bottom line?
4, 2, 6, 7, 3, 9.
And she got all the numbers correct. Had Andrika been an older individual who was using the near card and needed near glasses and had not brought them with her, we could correct her vision by using a pinhole. And these can either be purchased, such as this item, or you can actually make one by using exposed X-ray film and putting holes in it. The technique would be the same. One eye would be occluded. Cover your left eye. You may want to use your left hand. Good. And put the pinholes in front of your right eye. And again, the individual is asked to read the smallest line of font that they can.
4, 2, 6, 7, 3, 9.
Correct. It's even worth asking the patient if that made a difference for them, because in fact, if they do correct with the pinhole, that will only correct for a refractive error and not for a disorder of the retina or optic nerve. And if they got a lot better with the pinhole, they should be advised to see an ophthalmologist or an optometrist and obtain reading lenses. The next assessment is of the visual fields, and this can be done by confrontation, first each eye alone. There are 3 different methods I will demonstrate for the peripheral fields. One is confrontation with wiggling fingers, the other is by counting fingers in each quadrant, and the final one is with the use of a white pin. The approach is similar, using all 3 stimuli. You stand approximately 1 meter from the patient, or if you were both sitting, you want to be such that your eyes line up. The patient is instructed to cover one eye, and you cover the opposite eye. Andrika, please tell me when you see a finger wiggling.
Now. 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 Now.
Excellent. We can do the same thing with finger counting, and I'm going to show you either 2 fingers or 1 finger. And you tell me how many fingers you see. Cover your right eye. Look at this eye. How many fingers?
2. 1. 1. 2. 1.
And clearly Andrika is getting all the stimuli correct. The final way is with a white pin. Again, cover your right eye. And tell me when you see this head of the white pin as white. And it'll be moving as well. Say now as soon as you see it.
Now. 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 Now.
You cheated, you looked at it. Okay, keep looking at my eye, please.
Now.
And just as in this example, sometimes you have to remind the patient to maintain fixation on your eye. We can also assess central vision with use of a red stimulus. And to assess central vision, you need a colored object. And so a red pin serves you very well. Here you're really looking at the 15 degrees or so of the vertical and central meridians. The lines, as if you assume that that is central vision. Cover this eye. Look at this eye. And Andrika, I want you to tell me when you see the pin as red. Say now as soon as you see red. How about up here? Do you see the pin? Is it red?
No.
What color is it?
It's black.
Tell me as soon as you see it as red.
Now.
Keep looking at my eye.
Now.
Keep looking at my eye.
Now.
And you can see that when assessing central vision, in fact, the visual field is much smaller than it was for the peripheral fields. Finally, using the red pin, you can assess the blind spot. And most people aren't even aware that they have one. This is done by, again, asking the patient to close one eye. And the blind spot is located about 15 degrees off the vertical meridian, just usually a little bit below the horizontal. You line up your eye against the patient's eye, Enrica, I'm going to ask you to look at the red pin and tell me when its head disappears.
Okay.
Okay, sorry, you're going to look at my eye rather. Do you see the head of the pin? Tell me when the head disappears.
Now.
Okay, so I have to move my head just a little bit, and once I've done so, the head has disappeared for me as well. Tell me when the head reappears.
Now.
Gone?
Yes.
Tell me when it reappears.
Now.
Gone?
Yes.
Tell me when it reappears.
Now.
Gone?
Yes.
Tell me when it reappears.
Now.
Okay, gone?
Yes.
And you can see that there was a spot, known as the blind spot, where Enrica was unable to see the pin. When testing the visual fields in a patient, you assume that your own visual fields are normal. The third part of assessing the optic nerve is fundoscopy. This is performed using an ophthalmoscope. The lights are dimmed, and the patient is instructed to look off into the distance. This keeps their pupils larger, as they're not accommodating and decreasing their pupillary size, and also is less irritating to the patient. Keep looking off into the distance, Enrica. Do not look at the light. Approach laterally and observe the retina and the optic nerve. This is then repeated on the opposite side, again coming in laterally. The pupillary light reflex is also partly from the optic nerve. It supplies the afferent limb, whereas the oculomotor nerve supplies the efferent limb. And the pupils are assessed in a dim light. Before you actually do the pupillary light reflex, you may want to actually inspect the pupils. First, observe the pupils. Pupils should be round, regular, and equal. Typically, they are between 3 and 5 millimeters in size in a normal individual. Also observe the position of the lid. If the lid covers part or all of the pupil with the patient looking straight ahead, ptosis or lid droop is present. Enrica's eyes are perfectly symmetrical. So we assess the pupillary light response by shining a bright light in the eyes, and we would dim the lights. And the pupillary response is assessed by shining a light in one eye. Observe, as I shine in the right eye constricts. That is the direct response. Now observe Enrica's left eye as I shine the light in the right eye. That is the consensual response. That is the opposite eye reacting in response. Finally, you should test the swinging flashlight test by shining the eye first in the right, then in the left, and back and forth, and observing the eyes consistently constricting bilaterally. We also assess for the near response by having the patient accommodate. This is accomplished by asking Enrica to look into the distance and then look at the tip of her nose. Please look off into the distance and follow this item as it approaches your face. And we can see that not only do Enrica's eyes converge, but her pupils also constrict. If the patient has any difficulty following that command, you could ask them to follow their own thumb. Look at your thumb over here. Now bring it towards your nose and keep looking at it. Just bring it a little higher. And then, excellent. Next is the assessment of extraocular movements. When we assess for these, we're not only assessing the oculomotor nerve, but also the fourth, or trochlear nerve, and sixth, abducens nerves. First, the patient is asked to direct their eyes to the right. Look to the right, please. To the left. Look up, and look down. Then they are asked to follow a target as we assess their pursuit. Please follow this pen. Laterally to the left, laterally to the right, vertically up and vertically down. Then when looking to the left, vertically up and vertically down. And when looking to the right, vertically up and vertically down. That was pursuit. Now we assess saccadic eye movements, which are a quick eye movement. This is assessed by asking the patient to make a quick eye movement from one target to another. Enrica, look at my hand. Now look at the pen. Look at the hand. Look at the pen. Hand, pen. And to the opposite side, pen, hand, pen, hand, pen, hand. And vertically look up, look down. Up at the pen, down at the hand. Up at the pen, down at the hand. Finally, we can assess optokinetic nystagmus, which is assessed by using a stimulus that has stripes on it. This can either be an optokinetic drum, such as this, or a piece of fabric or paper with colorful lines on it. The patient is asked to simply watch the drum rotate, or sometimes they're told to try and count the stripes. Watch the stripes, and you can see quick nystagmus eye movements. Now to the opposite direction. Okay. And we can do that vertically as well. Okay. First down. Try and watch just the center of the drum. Excellent. And vertically upwards. Watch the center of the drum. The next cranial nerve is the fifth, the trigeminal, and this has sensory, V1, V2, V3, and motor components, V3. It's important to recognize the territories of the sensory components. V1 involves a distribution around the forehead and on the side of the nose. V2 is mainly the cheek, and V3 the chin. Be careful when applying the stimulus not to touch the angle of the jaw, as that is outside the territory of the mandibular branch. Enrica, I'm going to touch you with this cotton ball. I want you to close your eyes, and every time you feel the stimulus, just say yes.
Yes. Yes. Yes. Yes. Yes. Yes.
Is that equal on both sides?
Yes.
And you can see it's good to vary the rhythm a little bit so the patient doesn't fall into a steady pattern of just saying yes when they anticipate the stimulus may arrive. Facial sensation can be assessed very objectively by performing the corneal reflex. The afferent limb of the reflex is V1, or the ophthalmic division of the trigeminal nerve. The efferent limb is through the seventh facial nerve. The stimulus is a cotton ball formed into a wisp, and the stimulus is applied to the cornea with a direct stimulus to the cornea, and the eyes are observed to see both a direct and a consensual response. When performing the corneal reflex, you have to explain to the patient what you're going to do. Enrica, I'm going to take this cotton ball and very gently touch your eye with it. Okay? What I want you to do is look off into the distance, and it's important to actually touch the cornea and not just the sclera, because it is the cornea that is the most sensitive. So look up and to the left. And I want you to watch both of Enrica's eyes as I do this. It's good to rest your hand on the face so that you're nice and steady and deliver a quick stimulus. And you can see that Enrica blinked on both sides. So there's a direct and a consensual response. Pain and temperature is assessed with a pin. The pin should be a disposable pin, or you can use a tongue blade that you've broken in half, but these should not be used from one patient to another. The patient is asked to close their eyes, and they are either touched with the sharp or the dull end. Enrica, please tell me, is this sharp or dull?
Sharp. 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 Dull. Sharp. Sharp. Sharp.
Did that feel the same on the two sides?
Yes.
Now, temperature can be assessed by using the vibration fork, and this in ambient room temperature is usually quite cool. You can first test it against the back of your hand to ensure that it is cool. Its advantage over the pin is that the stimulus is a little more prolonged, and it's a little more consistent. With the pin, it's sometimes difficult to ensure precise delivery of the same intensity. So Enrica, this is cold, yes?
Yes.
Okay. I'm just going to touch you with this on your face, and you tell me if it feels cold.
Yes. 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 Yes.
Did that feel the same on the two sides?
Yes.
Now, had Andrika reported a problem with sensation, it is always easier for the patient to perceive a difference if you go from reduced sensation to stronger sensation. So you would start from the side of diminished temperature or pinprick and move to the opposite side. The motor mandibular branch is tested by jaw closure and opening. Ask the patient to clench their teeth and feel the temporalis and masseter muscles contracting. As well, ask the patient to open their mouth and then do so against resistance. Keep your mouth open, and the mouth should remain firmly opened and not deviate to either side. You can also test lateral movements. Andrika, move your mouth to the right against my hand with the jaw open, and to the left. And strength is normal. If there was weakness, the jaw would deviate to the side of weakness. The final aspect that can be done as part of the V3 is a reflex. It's known as the jaw jerk, and this is done by gently tapping on the jaw. So you want to explain to the patient, I'm going to tap on your jaw, and I'm going to put my fingers like this on your face. I want you to kind of let your mouth hang open. Support the jaw with your fingers. Andrika, I'm going to hit my finger. Just try and relax your jaw and let it hang. Deliver a downward blow with the reflex hammer. And in fact, Andrika doesn't really have a jaw jerk. You're seeing the stimulus being transmitted, but the jaw jerk, there'd be a bit of a delay and the jaw would come up.
So, that's everything with the first half. We are done with the first half of cranial nerves 1 through 6. And if you have questions, I'm waiting for questions. You're welcome to ask. And just for the future, I would like to add that I will have night shift on 13th, which you can attend since 4 p.m. And if no questions, then we're done for today and see you tomorrow at 2 p.m.
Thank you very much.
Thank you again for coming.
Thank you, Doctor.
Goodbye, gentlemen and ladies.
Goodbye. Bye. See you tomorrow.
Good to see you tomorrow. And we should shut down the stream.